Hi there, everyone. Welcome to the podcast of the European Society of Anaesthesiology and Intensive Care. I'm your host, Dr Paul McConnell from the Royal Alexandra Hospital in Paisley, Scotland. And today, we're going to be discussing the challenges that arise when parents and medical teams disagree. Now, this is a highly important and very emotive topic, and we'll be taking in and relying on the clinical expertise and knowledge of Dr Mia Gisselbaek from the University Hospitals of Geneva, who, though I believe, is joining us from Canada, if I'm correct in that. So welcome, everyone. Welcome, Mia. And thank you for agreeing to do this podcast.
Thank you so much for inviting me. I'm very excited about the discussion that will follow.
Great. So, Mia, probably the best way to start this is to have a wee think about when do these sort of disagreements arise? What should our listeners be careful of in different situations?
So I think that this disagreement can arise in a couple of situations. Because we are both a society of anesthesiology and intensive care, I think that the situation where these conflicts arise in anesthesiology and intensive care can be quite different. However, they can arise in both subspecialties. I would say that in anesthesiology, these types of conflict can arise regarding procedures, regarding which anesthesia we would pick, regarding the way of risks versus benefits, which can be different for the medical team or the anesthesiologist versus the parents. They can also arise in blood transfusion product management, and that's like one of the cases that is pretty much straightforward in many countries because it's the case that we encounter the most, I think. And then in the intensive care, the conflict can arise in many different situations regarding the management of children, regarding the pain, regarding the suffering, regarding the end-of-life decisions. And I think that understanding when this conflict arises in the first place can be very helpful, like noticing them straight away, but it can also be very difficult. I think that when the parents start asking many questions about many different things or asking for a second opinion, or they completely close and do not reply anymore or something, that can be hints that there is a conflict or that one will arise. And yeah, I think I've put over the question, but I would be happy to know your opinion too.
Yeah, I think that's really important. I think we can recognise as well that there's a big spectrum of things from what might seem very minor to us, sometimes within anaesthesia, maybe bits around, a choice of treatment or how we're going to conduct our anaesthesia, right through to big life-changing or even life-ending events in intensive care. And I think it's interesting because you've started to just touch on not just when these agreements arise, but how we can spot that they might be arising. I suppose for me, one of the lessons I've always learned is there might not be any small decisions when it comes to anaesthetising someone else's child, because I don't think there's any small decisions when it would come to anaesthetising my child. But just what you were saying there, maybe in your expertise, what are these sort of red flags that we can look for in behaviour, in sort of triggers that you want to maybe, as a clinician, spot early on? So you'd said maybe about second opinions, but other things as well.
I think when they begin to ask the same question in different ways, means that either they're not understanding what we are saying, meaning the specific words. But I think most of the time it's not about the words, it's more about what we want to convey or how we want to do things, and they do not agree with it. So they're trying to get us to say something else. Or they're not just like, there is such a big cultural gap that they are just not getting where we are, what we are aiming for. We can also see parents that would completely close, listen to what we say yes, yes, not really engage in what we're saying. And then they would be very bad inside, or I don't know how to say that in English. English is not my main language, but they would be very stressed out inside, in fact. So that would be like a coping strategy for them. We can also notice when they are asking for second opinion, as I already said. From my background, I think that's the main red flags I can see. I don't know if you have other ones. I know that there are plenty others, but that's the one that comes to my mind now.
Yeah, I think one of the other things as well is, again, you've touched on this, asking for second opinions, and that is both a sort of red flag, but it's maybe something also that we can both help with when we talk about sort of consistency. Now, there's this idea of the medical voice. Do you think it's important to have one medical voice, or at least a coordinated medical voice across these situations?
Yeah, I think it's extremely important to have one medical voice. Because, for instance, when we do anesthesia, we are not used to have multidisciplinary meetings, or at least not at my institution. And like the surgeon would see the parents, and then we would see the parents. And sometimes the risks explained by the surgeon are very much minimized. I find myself a lot in situations where I'm like, so your child is going to have a cardiopulmonary bypass, and then I'm just like explaining to the parents what is cardiopulmonary bypass, and they are struck with my explanation because they did not get this impression from the surgeon. I think it's really important that everyone has the same voice, even more important in the ICU, because when you have because in the ICU, I think you have multiple ways of handling things. It's always a balance between harms and benefits, or medical harms and benefits, more than if we don't touch on the spiritual ones and everything, because that's the other part. And I think it's extremely important that all the medical team agrees on what we are going to present the parents before presenting them. Because if we begin to present them with different information or different opinions, then they really don't know what to follow anymore or what to think anymore. And it makes us look a bit unprofessional in some way, because it makes us look like we don't really know what we're doing. Mm-hmm. And that's really something that, as a mother, I can tell you, if it were to happen to me, I would not trust the medical team. I think this has to do with trust a lot.
Yeah, I think that's a huge thing in pediatrics especially, but in medicine in general as well, the role of trust when it comes to patients consenting to a procedure or agreeing for something to happen. And they need that level of confidence in you. Now, you said something really important there, which I'm going to pick up on in a second, because you talked about medical interests and medical benefits, which would suggest there's other types of interests and benefits out there. Just before we go into that, you'd mentioned some cultural situations there. We tend to think of our help or assistance coming from other doctors. In your experience, are there other sort of resources that we could use as part of any mediation that might help us overcome cultural factors?
Yes. In my institution, well, I think one of, like, when we talk about different cultures, also in our society, we can have parents and children coming from that are like refugees, for instance, in Geneva or here in Canada. And one of the things that is really important to have them trust you is explain them the things in their own languages. So I think that's one of the things is having a translator. And I don't think that Google Translate or this type of device do the same as a real translator, because the real translator can also help you with cultural stuff, because most of the time you try to have a translator that is from the same culture as your patient, or at least from similar ones. And they can also explain to you the questions of the patient that the patient have and their concern in more depth. So I think that's one of the type of support we can have. But we can also have ethical support in my institution, or we can also involve spiritual persons or a person from different religions that would help us bridge a gap and explain to them why it's important. And they can also ask these people for opinion. So I think it's really important to know what resources are present in your own institution, because you cannot invent them, of course. And I'm aware that in Geneva we are very wealthy center. But yeah, really know what is there and know how to ask for help, and do that as soon as you feel like you need to.
So now what I'm going to do is take the lid off the can and let the worms go everywhere. And because you mentioned this idea of medical interests.
Okay. Yes.
You're a parent yourself, so a lot of your overall interests will also align with your medical training. But that might not be the case for everyone you encounter. How do you think that plays out in looking after children and things? Do you think we do need to consider things beyond just a straightforward biomedical model of a child's illness?
So to go a bit back on my background, I also have a medical sociology and anthropology background, and I do think that there are a lot of other interests than the medical one, and that we should listen to them. I do still think that we should not do harm. That's the principle. But if there are multiple options that are reasonable, and some of them would better fit with spiritual interest, with religious interest, with parental interest, we should really try to take that into consideration.
Yeah, I think that's amazing. You know, what you've said there, you've got two real key words that I think we don't sometimes think hard enough about as doctors, because you've talked about harm, but you've also brought up this idea of reasonableness. And I think sometimes we maybe become very focused on there being one right answer to everything, and maybe not taking into account the reasonableness of the parents' requests or the parents' beliefs for any situation. Is that something that you see sometimes?
Definitely, I would say. I think as doctor, we should be aware that we have a lot of cultural background, but this cultural background comes a lot from the culture of medicine. And I think the culture of medicine is something. And we need to take into consideration that there might be clash with other cultures, and that what we think is the most important will not be in another culture, and they will prevail something else. But that's really the not doing harm is one of the things that is the most important. I can give you one situation where so I was involved in a RCP situation where a 5-year-old child was brought from home and was in cardiac arrest. And as a medical team, we tried everything. We tried to give him his life back, but this wasn't possible. At some point, we decided as a medical team that we should stop the reanimation, which is already incredibly hard in adults, but in pediatric, it's just something else, another level. But then there was this mother that was here and was constantly telling us, just please 1 more minute, 1 more minute. I need this 1 more minute. And the pediatrician, which are much more trained, I think, than us in cultural differences and everything, they said, okay, we'll give her the time she needs. We'll continue the RCP, even though we don't believe that this is going to end up in a positive outcome. And I can tell you that there was disagreement within the team between ICU, PQ physician and anesthesiologist that wanted to stop, and the pediatrician that wanted to continue for the mother. And in the end, they involved a religious person that was able to come here, and they convinced them to stop. And in the end, we stopped. And I think that coming back on this situation, even though on the moment I felt a bit not okay with continuing, I still think that it was important for this mother, and that now she's the one that will have to live with that her whole life. Well, we also, but her on another level. And she needed that time to make peace with what was happening.
I mean, that is a hugely emotive a story, and a terrible situation for all those that's involved. But sometimes maybe as doctors, we do have our professionalism to fall back on, whereas parents don't have that. And we will go home at the end of the day and speak to our own loved ones and maybe have a glass of wine and put those situations, park them in a small area of our brain that occasionally we'll think about. But that will be the rest of that parent's life.
Yes.
And I think that's an interesting thing. Do you think sometimes part of the reason that we get conflict is we have professional guidance and we have guidelines and protocols that we can always fall back on. And there isn't really any guidelines or protocol for being a good parent. A good is just about doing the best you can and not giving up. Is that?
Well, I think it's completely true. There is no guidance. I think that perhaps, I don't know, because I'm not a religious person, but perhaps in some religion there is some guidance into what it means to be a good parent, and sometimes in some religion it would be not giving up until the end, or searching for a treatment even though there is not one that is proposed in one institution, and I think that we need to take into consideration that the parents, they try to rely on what they know. Mm-hmm. And sometimes it's worthy to explain to them like a bit more in detail to help them try to understand our point of view.
Mm-hmm. And perhaps as well, when we're framing that in some ways almost to not take decisions away from them, but absolve them from some of the consequences when the outcome is absolutely certain. Being honest that there's nothing that can be changed from that.
Yeah, I agree 100%. If it's a life or death decision or more an end of life decision, we should tell them that, I don't know if we should, but I know that helping them in a way is telling them that we will listen to them, but the decision is ours, that can be relieving for a parent, because then they don't feel like they have to make the decision themselves, and they don't have to live with this decision that they gave up on their child during their whole life.
And I think, so within, pediatric ethics and law, there is this thing in the UK called the paramountcy principle, where it's the welfare of the child that's paramount. But I wonder if that's taken as a very hard rule. And I wonder if sometimes what we need is a softer version of that still puts the child centre, but recognises all these other people, parents, siblings that are connected to them. And particularly if decisions made in behalf of that child in their best interests might be to the detriment of them sometimes.
Yes, I agree. I think that the principle that should prevail is not doing harm.
Mm-hmm.
Harm being based on what we know as a medical profession. But if there is no harm, we should definitely think about reasonableness. Mm-hmm. And within this spectrum of reasonable decisions, we should let the parents decide themselves.
Yes, absolutely. And I think that's really important. And again, not to lose sight of our role within the situation as medical experts, but some of the larger factors that are at play during all of these scenarios.
And I also think that if you as a medical professional, you let the parents take a reasonable decision that is not yours, you should not feel guilty about not picking your own decision, even though you think that's what's the best, because you should remind yourself that they're the parents and they're the ones that will exactly live with that their whole life.
Yeah, I think there's this idea of harm versus significant harm. And it's a bit strange because in the UK, if things go to the courts for social reasons, then the courts will only intervene and take children away from their parents if there's a risk of significant harm to them. But when it comes to medical decisions, it's done purely in best interests, as if there is only one answer. And maybe what we need to do in these situations is ask ourselves honestly, are the actions of the parents reasonable, and are they going to cause significant harm or not? And if they don't, I think a lot of stock should be put in what the parents are looking for. Would you agree with that?
Yes, I agree completely. And I think it should extend beyond the UK.
Yes, quite. We've talked quite a lot about recognising when these situations can happen, when they can happen. We've talked a wee bit about harm, about paramountcy. What about the use of, and we've talked about, with getting people from other cultures and other areas to help us. Do you have much experience using external mediation teams in pediatrics?
From my own experience, no, I don't have a lot of this experience. I am not even sure how I can get them to help, because the times we mostly used translators or person from other cultural background to help us bridge this gap. But I would be very interested to hear about your experience.
Again, it's something that's growing within adult medicine and ICU, the use of third-party mediators. And there is now a British Medical Mediation Society that sits outside of the NHS. And I think, again, sometimes in these scenarios, it's very emotive. We find it in adult ICU when the patients can't communicate. We have it in pediatric ICU, that we're trying to work under this idea of best interests. And the biggest trouble is no one can ever fully define what best interests are, but everyone thinks they're working in that person's best interests. And
Yeah, so
that's maybe where you get some of the conflict from. And perhaps maybe the biggest takeaway from this is for us as doctors, sometimes when is to recognise when there may be conflict or a disagreement unfolding, taking a step back and applying maybe a wee bit of empathy or thinking, at least in terms of where the parents' arguments for these things are coming from. Because I think only if we can understand those can we all move forward for the benefit of not just the patient, but the greater patient that's there.
yeah, I agree 100%. And I really think that there is not only one best interest. And that's what we should remind ourselves. Perhaps for us, there would be one best interest if we are like, if it was my child, I would do that. But that best interest that we define for ourselves comes from all the background that we have, all the experiences that we have had, all the past patients that we cared for. And I think that's really something we should bear in mind when walking into this difficult situation where we are not okay with the parents, is try to challenge ourselves and try to really think that what we are thinking is the best may not be the only option. And if those mediators team can help, definitely get them involved if you have some in your hospital.
Mia, thank you so much for sharing your expertise with us. It's given me so much to think about, and I'm sure it'll give our listeners a lot to think about as well. Thank you to everyone for listening to this episode. The ESAIC releases monthly podcasts on the ESAIC website and on various streaming platforms. We hope you will join us for the next one. But in the meantime, check out the ESAIC Academy to listen to more enlightening talks. Thank you for your time.